Second-degree AV block, Mobitz I. Second-degree AV block Mobitz I, also called Wenckebach, occurs when conduction through the AV node becomes progressively slower until one atrial impulse is completely blocked. On the ECG, the PR interval becomes longer with each beat, followed by a P wave that is not followed by a QRS complex, a dropped beat. After the pause, the pattern begins again. The atrial rhythm is regular, but the ventricular rhythm becomes irregular. Possible causes include increased vagal tone, inferior myocardial infarction, and medications that slow AV node conduction, such as beta blockers, diltiazem, verapamil, digoxin, or amiodarone. Many patients are asymptomatic and require only monitoring, medication review, and correction of the underlying cause. Frequent dropped beats can reduce cardiac output and cause dizziness, hypotension, syncope, or weakness. For symptomatic bradycardia, give atropine as ordered and prepare for pacing if the patient does not improve. A permanent pacemaker is usually considered only when symptoms clearly correlate with the block or when the block is located below the AV node. Second-degree AV block, Mobitz II. Second-degree AV block Mobitz II occurs when some atrial impulses suddenly fail to reach the ventricles. On the ECG, the conducted beats have constant PR intervals, but an occasional P wave is not followed by a QRS complex, producing a dropped beat. Unlike Mobitz I, there is no progressive PR prolongation before the dropped QRS. The atrial rhythm remains regular, while the ventricular rhythm becomes irregular. Mobitz II usually reflects disease below the AV node and may progress unexpectedly to complete heart block. Complications include severe bradycardia, decreased cardiac output, dizziness, syncope, hypotension, heart failure, and cardiac arrest. Monitor the ECG and vital signs, stop or review medications that slow conduction, and correct reversible causes such as ischemia or electrolyte abnormalities. Apply pacing pads and prepare for transcutaneous or transvenous pacing. Atropine may be ineffective because the block is usually below the AV node. Permanent pacemaker placement is generally recommended when Mobitz II is not caused by a reversible condition, even if the patient has no symptoms. Third-degree AV block. Third-degree AV block, also called complete heart block, occurs when no atrial impulses reach the ventricles. On the ECG, P waves and QRS complexes occur independently, with no consistent relationship between them. The P to P intervals are regular, the R to R intervals are usually regular but slow, and the PR interval constantly changes. This is called AV dissociation. Because the ventricles depend on a slow escape rhythm, cardiac output may fall severely, causing dizziness, syncope, hypotension, chest pain, heart failure, shock, or cardiac arrest. Monitor continuously, apply pacing pads, establish access, and correct reversible causes. If the patient is unstable, begin immediate transcutaneous pacing and prepare for transvenous pacing. Atropine may be attempted but is often ineffective when the block is below the AV node. Unless caused by a reversible or temporary condition, third-degree AV block generally requires a permanent pacemaker, even when symptoms are absent.